Northwest Eye Surgeons and Site Partners, I am Dr. Brett Bentz, and you're listening to The Focal Point, where we invite doctors and surgeons from the fields of ophthalmology and optometry to discuss the latest trends in medical eye care. For this podcast, we are going to direct our attention to the emerging field of microinvasive glaucoma surgery, or MIGS. These procedures, as we know from mild to moderate glaucoma, have been largely able to fill a welcomed void that had existed between maximal topical therapy, including SLT, and more advanced incisional surgery, such as glaucoma drainage implants and trabeculectomy. But we welcome Doctors Landon Jones and Justin Wright to the podcast. Doctors, thank you for being here today.
Thank you for having us, Brett.
Yeah, pleasure. Thank you again for welcoming us and inviting us.
As background, Dr. Jones works in a busy glaucoma and cataract partnership at our Northwest Eye Surgeons Northgate, Seattle office with surgeon Dr. Bruce Cameron and optometric physicians Drs. Emily Booker and Sarah Henderson. Dr. Wright also practices in a focused glaucoma and cataract surgery practice at Northwest Eye Surgeons location in Mount Vernon and Whatcom Eye Surgeons in Bellingham with surgeon Dr. Aaron Cousin and optometric physician Dr. Emily Freeman. So let's jump into it. Given the range of options for specific MIG procedures, where and how do you fit them into your overall glaucoma algorithms? And Dr. Jones, if you wouldn't mind being first.
Sure, I'm happy to. So as we know as glaucoma care providers, not everyone needs trabeculectomy, and not every patient is adequately controlled with their topical medications. And what we've found with MIGS procedures is that there's some middle ground there where we're treating patients with devices that aren't causing as much collateral damage or tissue manipulation as you find with trabeculectomy and with tube surgeries. So it's a blossoming field. We're very happy to have this technology available to us now as glaucoma providers because we all know that managing blebs is tedious. Blebs require a lot of care. They require a lot of chair time for our patients, and these blebs can fail over time. So oftentimes with our trabeculectomy patients, we are monitoring them closely. We're adding 5-FU treatments to reduce scarring. They just require quite a bit of care, and as we know, these patients are making several trips back and forth from the office. So what we like about MIGS is just their favorable safety profile. We tend to see less hypotony, for example, after the procedure. I mentioned that we're dealing with less tissue damage associated with creating a bleb, as these procedures can be done from an ab interno approach. And what we're doing by that as well is we're preserving real estate for future glaucoma surgeries if a patient down the road does need something beyond a MIGS procedure. We look at moving forward with these procedures based on how the patient's doing. So patient-driven approach. Are they having any adverse effects to their medication? Maybe they're having poor compliance to the medication. Those are reasons we'd move forward with something like this. And then also, is it doctor-driven? Is there progression of disease requiring additional lowering of pressure? And within this, we need to know if the patient qualifies, let's say for eye stent. There are qualifications based on the stage of glaucoma. We're also thinking about our targets and what we're trying to achieve by doing an additional treatment. And then we're also, of course, thinking about our patient's age, any comorbidities, their ability to come back and forth for their appointments. So that's where I'd start with answering your question.
Yeah, Landon, I agree. Thank you for your thoughts on kind of where you're at and where these fit into our medical surgical practice. For me, I think the only thing I would add is recognizing that part of the complexity or part of the concern that we deal with eye drops themselves is some patients are either not good at getting their drops in, whether it's just because they aren't able to physically learn very well to do that, or they don't remember. And so we're seeing some situations where patients have uncontrolled glaucoma status, even when they tell us they're using their drops. And so I think we have to have a sense of that going on and have to be watchful for that. And when they, especially when they are preparing to benefit from cataract surgery anyway, that we look at how to improve their eye pressure control, maybe not need as many eye drops depending on how many they're on currently, and really guide the future of their disease process, reduce the rate of reduction of nerve tissue over time by performing something when we can take advantage of already needing to be in the eye surgically anyway. Now, these procedures, MIGS, don't get me wrong, they don't only have to be done during glaucoma surgery. There are some that are FDA approved for that only, but I'm just speaking to the fact that especially when they're approaching the need or benefiting from cataract surgery, we should be thinking, okay, what else can we do to help their glaucoma disease state?
Well, that's an excellent point about combination therapy, because that certainly is something that most clinicians consider, especially when they have a concurrent cataract. Well, let's talk further about specific MIGS devices and procedures. Which of these does your surgical team prefer? And is there a process of patient selection that you consider in that decision?
Well, I'll start first with this question. So, of course, we have some MIGS options, but we should also mention, and I think you mentioned it earlier, Brett, we have SLT, and in our office, we're also offering micropulse diode laser treatment as well. I'll just mention those, not that they're in the MIGS category, but they are non-invasive treatments that are available to patients. We have no risk for infection with these types of treatments. We'd say that they are as minimally invasive as they come. So certainly a lot of our patients are being treated with these methods of pressure reduction. We get into the MIGS when maybe those lasers have been tried and the pressure is still uncontrolled, perhaps, or the most obvious one, iStent, has been used concomitantly with cataract surgery since it's only approved to do it that way. And the thought is, since the surgeon is already inside the eye, has already made a clear corneal incision, that go ahead and spend another minute or two injecting an iStent into the Schlemm's canal to help control pressure that way. So you basically have the same safety profile as if the patient had cataract surgery, but now there's an opportunity to perhaps get them off one or even two medications. So the science says this procedure is usually lowering pressure by 5 or 6 points for a majority of our patients that are having it done. So that's a great one that's available during cataract surgery. And Glaukos, who has created this stent, has also come out recently with one called Infinite. And this one has been approved for a standalone procedure. So same idea, that it's implanted there, and we can do up to 3 instead of just 2. And that way we can potentially, like I said, remove a topical medication from the patient's treatment regimen and get better control with a minimally invasive procedure.
Right. So, Landon, the goal of using 3 stents instead of just 2, the company's now loading the device with 3, is really to access additional collector channels. So the surgeon placing those stents will try to access as far supranasal and infranasal with 2 of them, and then probably place 1 again straight nasally. I think it has the potential of offering some additional pressure lowering. We know that the eye stents can even stop functioning as well over time, and so if we have more in the eye, I do sense that will help us have better functionality. My understanding is that the iStent Infinite is also looking to be FDA approved for use in severe stage glaucoma, which will be an interesting decision-making process. I don't know how often we'll actually lean that direction, but previously the iStent was only approved for mild and moderate glaucoma, and so it wasn't even really a choice we could employ when it comes to a patient with more visual field damage that in a sense has severe stage type glaucoma. So it does have an opportunity to provide us with an additional tool. I think it's one we look forward to utilizing. I'll share that Dr. Cousin has taken to a canaloplasty ab interno approach. So using a device called an eye track, he during cataract surgery or at a separate time, standalone procedure, he'll go in through a clear corneal incision, same incision he would make during a cataract surgery. He then is accessing with a gonio lens, near a special gonio prism lens, surgical to the nasal aspect of the trabecular meshwork, makes a small dissection, is able to wind the eye track with a blinking light all the way through the trabecular meshwork, unless he meets resistance. If he does, he tries to go the other way as well. And then as he extracts the eye track, which is luminar, it has a tube, it actually ejects viscoelastic through the tube, which puts the Schlemm's canal on stretch. So it's changing the diameter and tissue space. And then nothing else is left in the eye, just the viscoelastic, which of course reabsorbs over a period of time. But again, pretty effective way to also lower the pressure effectively. We're seeing good results getting patients off of 1, 2, sometimes 3 drops. And so one that even compared to an iStent, we're doing, I would say, about the same amount, canaloplasty ab interno versus iStent currently.
You both have brought up excellent choices for these procedures. And just top of the head, there's so many we could talk about, and I'm sure you have experience with some of these. The canaloplasty was an excellent example that you brought up, Justin. The other one that comes to mind now, I know that Dr. Cameron has favored Zen procedures. Dr. Landon,
yes.
Is he still using those?
Yes, we're still doing Zen surgery. It's an ab interno approach to creating a bleb. So you might have some naysayers say this is kind of getting out of the realm of MIGS procedures since we're dealing with a bleb following the procedure, but it's certainly less disruptive than these other filtering surgeries we've mentioned. It also takes our surgeon about 10 minutes of time, so it's a relatively quick procedure. And basically, this small gel stent is implanted from the anterior chamber into the subconjunctival space. It's a little bit of a finicky stent, I will say. It can sometimes curlicue, be misshapen, and sometimes has to be revised a bit. But when it's in there properly and is creating a bleb, we tend to see nice lowering of ocular pressure. We just have to manage these patients as you would a trabeculectomy patient, in that the bleb has to be monitored. You can get some encapsulation around the implant. And so they may need 5-FU injections postoperatively, requiring your surgeon to be close by. And then sometimes we'll have our patients also apply massage. I just had one today that I initiated massage to help keep the pressure down. And we will sort of go this direction as an alternative to trabeculectomy. So now we're kind of talking about a lower target pressure with these patients. So, for example, if we have a pressure of, let's say we're trying to get to 15, that seems more doable with some of these other procedures we've mentioned, or the iStent. But if we're trying to get a target pressure of 11 or 12, then you're probably going to have to implement something like Zen surgery, similar to a trabeculectomy, to get the pressure down to target.
One thought I had as Landon was talking is just a reminder that, just because a MIGS procedure is performed, it doesn't guarantee that a patient's going to be able to be off of topical eye drops. Still, a combination of the two is sometimes what's really needed to maintain glaucoma long term. And so don't for all of our listening docs, don't be shy in restarting or re-adding or having the patient continue medications. Our protocol over the years has been to just maintain them on their current eye drop status until they've healed for about a month, partly because they're on a topical steroid while they're healing from the procedure itself. And so it's after that month that we start to look at taking them off of medications. But again, if the pressure rises back to a range where we're concerned, don't be shy of restarting a medication. So good procedures work really well. Still needs to be monitored and addressed and carefully kept under our watch so that the disease process stays managed well.
Well, that's the end of our time today. So thank you, Landon and Justin, for providing your perspectives and rationale for the management of these patients with MIGS procedures. No question that in the prevailing treatment algorithm, that there seems to be a clear consensus that MIGS are a welcomed, lower risk alternative compared to the more invasive glaucoma procedures. Interesting that we will have our two glaucoma surgeons on an upcoming podcast that compares trabeculectomy and glaucoma tube shunt procedures. That's this week's edition of The Focal Point. If you enjoyed today's podcast, please subscribe and tune in next week for another episode and update on medical eye care. I'm your host, Dr. Brett Bentz, and thank you for joining us.